And so this webinar is going to bring together all the best practices in infection control management for SARS-CoV-2 virus. And as you'll see in a moment, we did ask input from all of you, and we got some really great suggestions for questions. But first, we're going to go over the objectives. So I'll be reviewing the basics of infection control and the differences between common infection control terminology. Like, what is the difference between when you quarantine somebody, isolate a cohort, a group of residents? Review PPE and testing recommendations, including how to source PPE, some of the infection control best practices and understand how to implement them, understand how to create an infection control culture and really success in implementing an infection control plan, and then how to identify both the CDC and DPH guidelines for residential care home settings. We did some polling ahead of time. We asked some questions of the group. For those of you who had submitted the responses, we said, one of the question was, have you had infection control training? So a fair amount of you have, 77%. And we're delighted that maybe those that didn't are on this webinar for that additional training. Hand hygiene signage in your care centers, 100% of you have that and access to PPE. And then IP plans in place, 94%. Now, some of the barriers, which didn't surprise us, that the leading response to barriers to quarantine or isolation is the mental health state of the residents and the challenges there, or your physical plant and space constraints was a big issue. Patient compliance post-vaccination. Many people think because they've had complete vaccination, they no longer have to do any infection prevention measures. That's very common even in the community now. Shared bathrooms, keeping residents engaged in IP practices, patient mobility and their independence, PPE compliance, employee compliance, and it sort of goes against what's normal in your settings. That was, I thought, a really good response from a few of you, that this isn't your norm. And so it's been very, very challenging to implement infection prevention measures in those settings. And so some of the pre-webinar responses were talking about how to balance infection over well-being when you have infection control practices, how to determine the minimal safe level of isolation for various conditions, how do we keep our residents and staff safe while operating in our activity programs, prioritizing infection control methods and what's really important and effective to control the spread. And then after vaccinations, how long should the quarantine be? How to ensure staff follow infection control procedures 100% of the time. Will variants of COVID affect the outcome of vaccinations? Right now, none of us know that. We're hoping that it won't mutate as more and more of us get vaccinated. Pathogens on surfaces and how to disinfect versus cleaning and sanitizing an area. How to keep illness from spreading through the rest home. Overall, reviewing best guidance for infection control and what a plan looks like. Can we still mandate mask wearing for staff who refuse to get vaccinated once the restriction is lifted by the Commonwealth? We did that with influenza, as you remember. Influenza vaccinations were required, and those staff that either couldn't get them or didn't want to get them had to wear a mask. So I would imagine that might be the same for this. COVID testing frequency, does vaccination provide long-term protection? Again, we're not sure. Time's going to tell in another year. And when cohorting residents, should we be doing this 14 days and 2 negative tests? And I'll go over the CDC guidelines on testing because that's what the states then draw from. And make sure you keep on top of what your state is telling you, because sometimes the state will veer from what CDC is saying and might have different guidelines. First, let's look at this very unique coronavirus. So what is SARS? Sudden acute respiratory syndrome, CoV-2. We have a SARS-CoV-1, and we also have another strain called MERS-CoV from Middle Eastern respiratory syndrome. But there are actually 7 coronaviruses, and there are 4 of them that are causing severe illness. And so this is the latest coronavirus, SARS-CoV-2. We'll look at some of the common symptoms and testing requirements. But first, when you're an infection preventionist, our head is kind of trained to first look at the chain of infection. And so we look at what is the infectious agent in this situation, SARS-CoV-2, and where's the reservoir? Well, the reservoir is people. It's not really the environment. One good thing about viruses, they don't like the environment. They have to manufacture within our cells in our body, not like MRSA or C. difficile, which very easily can contaminate an environment and serve as a reservoir. In this situation, the reservoir are humans. Its original reservoir is probably in bats and other species that then started to become common in humans. The portal of exit is through the respiratory tract or secretions. The mode of transmission, we're going to go over that. Some of it, there are 4 different types of transmission as it moves along. But with this virus, and how we know this is that it's more of a air current transmission, a bioaerosol transmission, because we've got influenza very well under control with all these measures, as we'll talk about the prevention measures like, PPE and hand hygiene and social distancing, but not this one. This is still transmitting because of the bioaerosols. Portal of entry is through your nose or through your eyes, and then the susceptible host can really be anyone, but we'll talk about the higher risk categories for this particular virus. It was named corona because of this crown-like spiking on the virus's surface, as you can see here. And really, this is not so much a respiratory virus as it is almost like a blood virus. It damages the inside of the blood vessels and shreds the lining. And the lung tissues of COVID-19 patients had 9 times as many tiny blood clots, or microthrombi, they call them, compared to those who had influenza, which is a respiratory virus. And the coronavirus infected the lungs, but also exhibited severe damage to the thin membrane in the lungs called the endothelium. So these are the current stats as of March 29th. That globally, there have been 221 countries. And when you consider that just about a year ago, we all started to learn about this, especially in the middle of March when we went into a quarantine as a nation. We now have globally 127, almost 128 million cases with 2.7, almost 2.8 million deaths. And in the US, we've had almost 31 million cases with over 560,000 deaths. And things are starting to slow down. But if you want to keep on top of the statistics, this is a great website, Worldometer, and you look for coronavirus, but it will give you everything that's going on in the world, how many cancer cases or any other kind of statistics you might need for a project, and you're looking for stats on what's going on in the whole world. So how it's spread is by 4 different routes. We have direct contact, where an individual is exposed to the infectious viruses by direct physical contact with another person. That's why we don't want anybody shaking hands anymore or hugging and getting that close to somebody for a direct contact. Indirect contact is when you pass something, a physical object, to somebody else. In hospitals, it could be a stethoscope, for instance, but in care settings, it could be a puzzle, it could be a book. You have to kind of look around and see, what devices do we have or pieces of equipment we might share that need to be wiped down between each resident use. And that's an indirect transmission. Droplet transmission is the most common. And so the individual releases these infectious agents called droplets, and then they land very close, within 3 to 6 feet of another individual, and they inhale them, or they get them up in their eye, but mostly it's inhalation through the nasopharynx. Now, airborne transmission, as I mentioned, is moving along through bioaerosols, but an area where it's most dangerous is during what are called aerosol generating procedures, which we'll talk about a few that might be done in your types of settings. In the hospital situation, it's more involved with things like intubation, both in the operating room and emergency room, where they're actually going to go right down into that respiratory tract that's infected. But coughing is one of the best ways for it to get around. And so when you look at coughs and sneezes, they play a key role. What is a cough? It's a mixture of mucus and phlegm and irritants and fluid, but it can have infections such as a coronavirus in it. They can travel very fast, 50 miles per hour, and expel almost 3,000 droplets. And the direct jet can spray droplets out to about 6 feet. Some droplets will settle and land on your surfaces, such as doorknobs and tables, and they can stay viable on inanimate surfaces anywhere from 1 to 9 days. The lighter droplets then become airborne, and they travel faster, and they can move into somebody else's respiratory system or get up into ventilation systems. So one of the most best conducive environments for transmission is closed spaces that don't have really good ventilation, or windows are not being open to, dilute the air. And that's why homes and settings like yours were probably more at risk, in nursing homes, for instance, of transmission due to that fact, that they don't have the big high-vac systems that they have in, like, for instance, in hospital settings. So some of the common symptoms that may occur 2 to 14 days after exposure Fever, typically in younger individuals, but as you probably know, elderly residents often don't develop a fever. I have a mom who's 88, and that's one of our biggest challenges is trying to figure out when she has an infection or a urinary tract infection. She doesn't develop a fever. And often it's more of a mental state change that we know something's going on. Often with this, there isn't a cough. Sometimes that happens even with influenza. And the reason for that with this particular virus, it gets a ground glass opacity throughout the lungs versus when you have pneumonia, we typically look for infiltrates, kind of like this consolidation in the lung where the bacteria or even a virus is causing, and they say, oh, the patient has an infiltrate, they have pneumonia. Well, this way, this virus infiltrates all through the lungs and the air sacs, and it looks like literally on the x-ray like ground glass, and that's what they call them. Then there's shortness of breath or tightness and heaviness in the chest. Loss of taste and smell. And they say that when people get this and that's the only symptom, often they don't know how damaging the virus is because it's going up through, if you think about it, it's going into the area where you're going to have in your brain taste and smell. And so therefore that's a sign that somebody's just got to really watch themselves that they don't progress to a severe case of COVID infection. But there are certain groups, everybody's at risk, obviously, but some of the settings that some of you have residents would be those who are 65 years or older, have cardiac disease, as I talked about earlier. This is kind of a blood vessel disease, and it actually affects a protein called ACE2 protein that coats around many of our organs. So that's why people that have cardiac issues, diabetes, respiratory diseases, people who are obese or immunosuppressed, and then residents of long-term care settings, residential care homes, congregate care sites. And then people with COVID have had a wide range of symptoms reported, ranging from very mild or even asymptomatic to very severe. So the treatment and prevention has dramatically improved over the last year. I mean, the key thing is prevention, which is what this webinar is about. We've got to stay on top of these control measures, even with all the vaccines, and not let up. You know, washing hands frequently, avoiding social contact very closely, you know, trying to stay within that 3 to 6 feet from other people, covering the mouth and the nose, also everybody wearing a mask, cover coughs and sneezes, clean and disinfect surfaces often, and monitoring your health, getting care if you don't feel well or getting tested. Vaccines, we have 3 available at the moment. Johnson & Johnson, which is a 1 dose. That's starting to get manufactured more of those because it'd be much easier for many situations just to be able to give out 1 dose and not have to have a second appointment, which you need 2 doses for Pfizer and Moderna. Current treatment are a whole bunch of drug combinations that they've finally figured out over a year that are very, very helpful, especially getting things like a prednisone kind of a drug and oxygen on board very early. So they've been able to not intubate people like they did in the beginning as often. And it's really improved, and we've seen significant reduced mortality as a result of that. Testing for COVID, there are CDC guidelines for residents and staff in residential care homes. But timing is the most important. So if you're exposed to COVID, it's unlikely you'll develop symptoms immediately after exposure. You know, the virus has got to get in your body and start manufacturing itself. So it goes into your cells in the nasopharynx. It starts to go into the cell, and, you know, with those spikes, it drops down into the cells, information, and to be able to manufacture itself. They use our cells like manufacturing factories to make more viral products and babies, I say, and then they move off into the stream and hit off into other organs. But if you get tested and you're positive, you need to be isolated. But if you're negative, that doesn't mean you're out of the woods. It could mean that you're in what's called an incubation period. And that can take up to 2 weeks where you're going to be quarantined. So that's why testing, if you get exposed, they typically will recommend you wait at least 4 to 5 days after the exposure so you don't get a false negative. Your body may not have been able to produce enough of a response for the test to pick it up, especially the rapid test, for instance, versus the PCR, the polymerase chain reaction. So testing residents with signs or symptoms of COVID, the clinicians should use their judgment to determine if the resident has signs and symptoms consistent with COVID and whether they should be tested, is what CDC says. But if it's an asymptomatic residence with either known or suspected exposure, perform expanded viral testing of all residents if there is an outbreak in the residential care home, or a new infection in a healthcare professional or a resident. Initial baseline testing of asymptomatic residents without known or suspected exposure to an individual who is infected as part of the recommended reopening process. So in any residential care home, initial viral testing of all residents, and that's what we call getting a baseline. These are people who are not known to have previously been diagnosed with COVID. This is recommended because of the high likelihood of exposure during a pandemic, the transmissibility of SARS-CoV-2, and the risk of complications among residents in those settings. And then testing to determine resolution of infection. So these are the 4 categories in the CDC guidelines. And I took the guidelines from, they were January 7th. And that's the other thing I'm always looking at and putting on my slides, the dates, because things change, as you all know, almost daily when it comes to the CDC. So we constantly, as consultants, especially Commonwealth Medicine, the group of us that are working and doing this consulting, we're on top of these guidelines constantly, whether it's both at the Mass Department of Public Health, but also the CDC. So also the testing to determine resolution of infection, a test-based strategy which requires serial tests and improvement of symptoms should be considered for discontinuing the transmission-based precautions, and we'll talk about what those are, earlier than the symptom-based strategy. However, in most cases, the test-based strategy results in prolonged isolation of residents who continue to shed detectable SARS-CoV RNA but are no longer infectious. So this is where you need guidelines from experts, whether you're working closely with your Department of Public Health or you're working, for instance, with consultants, and they can help you set up your infection control plans and what is the best strategy with testing for your setting. So testing healthcare professionals in residential care homes, these were updated February 16th. So testing a healthcare professional with signs or symptoms, they should be tested and prioritized for the SARS-CoV testing. Testing asymptomatic or those who had a suspected exposure as part of community contact tracing efforts, viral testing is recommended for the staff who have had close contact with persons with COVID-19 in the community. So we leave that up to them. I mean, they've got to be honest and let us know. I know one setting we were working in where the healthcare professional was exposed to it, her dad, and didn't tell the facility, and ended up causing quite an outbreak in that setting. But she, I guess she just wanted to work, and she didn't think she was going to come down with it. But unfortunately, she had an asymptomatic case of it and didn't realize that she had exposed many of the residents in that facility. Testing asymptomatic healthcare professional who without known or suspected. So here they say currently testing asymptomatic staff without known or suspected exposure to SARS-CoV-2 is recommended for the staff that work in residential care homes. So most of you probably have some sort of testing regimen. In that facility I was talking about, they started, their staff were being tested every 3 days, for instance. And everybody was wearing an N95 and a face shield. Even as consultants, when we came in, we had to switch from our masks that we had to an N95 and a full face shield. And that was one of their strategies to try to get that under control. And testing to determine when a healthcare professional is no longer infectious, the test-based strategy, which requires serial testing and improvement in symptoms, could be considered to allow the staff to return to work earlier than the symptom-based strategies. However, in most cases, the test-based strategy results in prolonged work exclusions of a staff who continue to shed detectable SARS-CoV-2 RNA, but they're no longer infectious. So that's the key. Once it's been inside your body and it's taken over your cells and you've had your infection inside the body, it's no longer coming out through your mouth or your nose during sneezing, coughing, and talking or singing and other ways that we move things out of our upper airways. So that's what's tricky. You may have somebody who's recovering from having had a SARS-CoV-2 infection, and they may have detectable RNA, but they are no longer infectious. So that's why it's really good to have a group of either consultants or working with DPH to determine, what's the best strategy for your setting in getting people back to work and not keeping them out for, months. Some of these people can continue to have positive tests for a long time, but they're not infectious. So Some of the definitions, which come from this website up at the top here. What a quarantine means is it separates and restricts the movement of residents who were exposed to a contagious disease, in this case SARS-CoV-2, to see if they become sick. So you may have had, maybe even last year, probably more, a quarantine area separated who were exposed to it, but they weren't sick at that point. But you knew that all of them had to be quarantined. We've had to do this a lot of outbreaks I've handled in hospitals where we had to have a quarantine unit, or in a nursery. Once I had an outbreak and one part of the nursery was quarantined while the other infants were not, because they had all been exposed, the ones in quarantine. Now, isolation is we separate a sick, now this is somebody who actually has COVID, from other residents who are not sick. So that may be a private room situation that they're separated off, or you have too many who got sick and you have to cohort. So what you do is you set off an area, maybe that's a set of 4 rooms or a second floor, and you identify that that's going to be the area that they're going to be confined as a group of residents. And then those who are fully vaccinated, referring to residents who have more than 2 weeks, so they need 14 days following the second dose, if they had the Pfizer or Moderna, or 2 weeks following the receipt of 1 dose of a single dose vaccine. It takes about 2 weeks for us to build up the antibodies in our body. It's a result of whether you're getting the messenger RNA vaccine, which is Pfizer or Moderna, or you're getting a viral vector. So the J&J is a different type of a vaccine, requires 1 dose, very similar to some of the vaccines we've had in the past, where they're using a viral vector rather than the messenger RNA concept. So now let's look at airborne transmission. What does that mean? What are some of the aerosol generating procedures that can transmit SARS-CoV-2 in your types of settings, and how to mitigate airborne transmission in your settings? What happens with airborne, these larger liquid droplets convert to droplet nuclei, and we call these bioaerosols. As the liquid evaporates, this non-evaporative content concentrates until a droplet nucleus develops. These droplet nuclei could remain suspended in the air for longer periods than the liquid. So when you see that kind of a cough, and one thing I've come to understand throughout my life is that people have different types of coughs. Some people hold it in, they'll sneeze and kind of hold it in. Other people really make an effort to contain it by putting their shirt over the face, which I think is one of the best things, not your hand, but a shirt or into your arm. So all of that material that's coming out, those droplets, get confined and contained. And then you have others who just like to explode it out. And as I said, 50 miles per hour, and it can go pretty far out, 3 to 6 feet. Now, by gravity, it's going to take that material and drop it down to the earth. That's what happens with larger droplets, 3 to 6 feet. It's different than aerosols. So we have some aerosol diseases like tuberculosis, chickenpox, and measles. Now, they will suspend for hours. Sometimes the worst thing we could have in a hospital setting would be a chickenpox or measles or TB exposure, because we know we got shut down rooms for 8 hours, and contact tracing for everybody that might have been around, because it can take off and move through the air. These bioaerosols, what happened is they start to suspend, and maybe they stay up there for about 3 to 6 hours, and then they start to move down, as we talked about, to the earth. So this is why we need face protection, and why we still need face protection. It's very critical that people don't get lazy now that they're getting their vaccines and think, well, I'm never going to have to wear a mask again. We don't know yet how many people have had the vaccine could develop a variant strain of COVID from a strain that vaccine didn't work against. That's, again, we're in the middle of trying to understand all of this. But these viruses can remain in these bioaerosols for 3 to 6 feet and travel distances. So exhalation, loud talking, sneezing, singing, and coughing, how individuals, as I said, they have different amounts of aerosols. You can just see the differences in these pictures here, how different when they've done these studies, what comes out of somebody's mouth when they're coughing or sneezing. But these micro droplets remain aloft in the air at distances beyond 3 to 6 feet and can stay suspended up to 3 hours. Micro droplets maintain their infectivity in these smaller droplets. So if you happen to be there and inhale them, they can get up into your nasal passages and then start to replicate. I'm going to talk about even innovative things you could do to try to prevent that, not just wearing masks, but a few other innovative things that have come to our awareness and infection prevention that can help with that situation. So you can see why one person can affect easily two, and those two people easily two more to four, those four easily to 16 to 64 and so forth. And this is why it just took off so fast in certain settings where it started to spread because of that bioaerosol transmission. So aerosol generating procedures, we have these aerosol particles, as I mentioned, called these bioaerosols coming out of the respiratory tract. But when we suction a patient, we generate more of them. So that's why in ICU settings, they have to be so careful with maximum PPE because of the amount of respiratory treatments they're doing. And we also can have things that have exhalation ports like ventilators or like nebulizers or CPAPs. Those could be some of the aerosol generating procedures on a COVID resident that you have to be careful with. So during those kind of procedures, the CDC recommends that PPE be worn, an isolation gown and then 95, protecting your eyes with a face shield or goggles or safety glasses, wearing gloves, limit the number of staff, the healthcare professionals present during the procedure, and then following the procedure to clean and disinfect the room and open the windows if possible. I think that's underestimated in many settings, that if you just can flush out the air, keep the windows open. I know it's really cold during this period of time, but that's a really good control measure, is just to try to dilute the air in settings. Now we'll look at PPE and evaluate the various face coverings, masks, and respirators, how to put on and take off what we call donning and doffing of PPE, scenarios when it should be used in sourcing of PPE, challenges. Everybody's having challenges. It's gotten better as the manufacturers and actually having imports coming in from other countries that have brought us PPE. So it's not as bad as it was last year, but some places still have a challenge in accessing PPE. So we have what's called standard precautions. Now, this was developed back in the late 80s after the HIV virus became apparent in the early 80s. And we started to see healthcare workers come down with HIV. Some of them were from a blood body fluid splash that ended up in their mouth or their nose or through a cut on their hands. And others were direct inoculation from needle sticks. And so we started to use on every single patient, we treat them, we still do this, as if they're infectious. So it was called standard precautions. Treat everybody as if they're infectious. And that means that you perform hand hygiene a lot. Before you touch somebody, while you're in the room working with a resident, and after you leave that setting. And also outside in the community, just lots of hand hygiene, which involves either hand washing or the use of a sanitizer. And then covering, respiratory etiquette is like what I mentioned earlier, covering your coughs and your sneezes. Here's somebody using it with the tissue, but also if you're going to cough or sneeze, using the inside of your arm or underneath your shirt, so it can confine and contain it on the clothing. Once it's on the clothing, that's not going to then jump off your clothing and up into your nose. Obviously, if you've got a bad infection, you want to change your clothing often if that's happening, but it just is a better way to confine and contain it. And then PPE waste disposal, how to use the equipment, and then how properly get rid of it. As you see probably in the environment, lots of masks all over the ground, and people are not disposing of those properly. And then environmental cleaning and disinfection. We'll talk a little bit about the proper way to do that. Now, transmission-based precaution means we go a little step further. So we're still using, it says, in addition to standard, we're now going to have contact precautions. And basically the concept here is, if at all possible, try to have them in a private room, and everybody going in the room has to wear a gown and gloves. And then because it's COVID, in addition, some kind of face covering. Droplet precautions, in addition to standards in healthcare settings, for the most part, meant put them in a private room and we only had to wear a mask going in. But with COVID, we're using both contact and droplets. So we're wearing the gowns and the gloves, as you just saw with aerosol generating procedures. Now, airborne precautions is a little different. For chickenpox, measles, mumps, diseases like that, we put them in a negative pressure isolation room. And those are rooms that are going to suck the air out 12 times an hour through a HEPA, a high efficiency particulate air filter, HEPA. And they're going to take it to the outside of the facility, the building, and draw in fresh air. And then every 12 times an hour, clean it out. So that is not what we've been able to do with COVID. Some hospitals and settings have purchased HEPA filtration units. Some residential care settings have gone on, like even Amazon, and bought a machine that will at least do once an hour through a HEPA filter. And these machines might run around $400, $399 for a machine that will do a 1,500 square foot space. And so that's just an added protection that some places have done to try to get sort of an airborne precaution. But as I said earlier, we consider SARS-CoV-2 droplet, but it's because of those bioaerosols that it's given us the challenge we've had of making it more look like airborne. So therefore, we have different kinds of masks and respirator protection. We have homemade cloth masks, which are okay for low risk jobs or just for the public. They keep the saliva and, sneezes and coughs, at least a major amount of that from, or like I said about the clothing, from moving out into the air. And there are many different types that can be purchased or made on their own. Then we have disposable. We have surgical, or some call them medical masks, which are more for a medium risk job. And these are really better at keeping those droplets from escaping into the air because of the different layers that they have. And then we have the best protection, which is an N95, a NIOSH approved N95 respirator. And those are really going to keep 95% of those bioaerosols out of your nose. And so that's why we've been using those a lot more in healthcare settings. I see a lot of people now in the public and on airplanes using their own N95s now that we have access to them. So there are many companies you can now buy them very inexpensive, less than $1 in a lot of settings in N95. I know one setting where they're giving 5 a month, $2 each. And it's kind of like, a service. You sign up and you're going to get 5 of them for once a week, pretty much. And then they'll just send you for $11. They'll send you 5 respirators every month. So there are a lot of people doing that rather than try to run out to a Lowe's or somewhere else to try to find an N95. What also many of them are getting in the public are, by the way, KN95s versus the N95. We're trying to reserve N95s for the public. And what an N95, both of these are made of multiple layers of synthetic material, a polypropylene plastic polymer. And both masks filter out and capture 95% of tiny 0.3 micron particles, these small bioaerosols. The difference is that the KN95s are typically regulated by the Chinese government. So we've been able to access and get a lot of those into our country, versus the N95s are regulated by the National Institute for Occupational Safety and Health, or what's called NIOSH in the United States. The approved KN95s will perform just pretty identical to N95s. They have virtually the same filtration rates and therefore equally safe if they're properly certified. This is from the CDC website to share with your staff how to effectively use masks. So the best kind of a mask, even a cloth mask, has a nose wire in it so that you can really push this around the top of your nose. There are these mask fitters or braces. I haven't seen anybody wear these, but I think it's a good idea. They're just kind of a silicone material, and you put them over your mask so that they give you much better protection to seal it so you don't have that leaking around the edges of your mask. Making sure that it fits snugly and that you don't have any gaps on the side of the mask. Add another layer. So there was a recommendation that we start to consider using 2 masks. So what that would mean is having a medical mask underneath and a cloth mask over that. I'm seeing more of that people are using 2 masks. What that will do is the cloth mask will get the larger amounts of droplets that come out of somebody's mouth and trap it. And then you have the medical mask underneath with all the different layers, preventing those smaller particles from getting through. And this is really typically for the public, not so much in the healthcare setting. Most of them are using, if they're around COVID patients, you're using an N95. And then there's knot and tuck ear loops of a 3-ply mask. And there's this video that's really great that shows very quickly how to take a mask and just kind of turn the loops so that you have a better protection of the mask. So this is what CDC is trying to do, is educate the public to wear masks better and clean them and change them. Some of the conditions of masks that I see are offering no protection. You know, people get lazy and just put them in their car or in their pocketbook, and they're not changing them or cleaning them. So that's the danger with cloth masks. I think we're better off having disposable, and you dispose of them. And then they do not recommend that you put two disposable masks, are not designed to fit tightly. Disposable mask. So that's why they said if you have a disposable underneath, cover that with a cloth mask, and not to combine a K95 or N95 with any other type of mask. I have seen people walking around with an N95 or KN95, and then they have a mask on top of it. That will really be difficult to breathe through. That's their major concern, is the effects on the lungs. The N95 or KN95 does its work, 95% filtration. So it's really not necessary to put another mask on top of it. So as I mentioned earlier, here's something unique that has come out and is being used by many hospitals. By the way, they have started to purchase nasal antiseptics for long-term protection. Because what happens with the nose, as we mentioned, this is where we have glands that produce the mucus, and we have a lot of hair in our nose. And that's our first line of defense to filter out things like dust and lint and dirt and bacteria and even viruses, to trap it in that area before it gets up into that big, what's called nasopharynx. And that's where the virus starts to replicate. Not in the anterior nares, which is where these little lumps are around the front of your nose. That's the anterior nares. And that's where we typically will take a swab if you're coming in for surgery, especially orthopedics, and we will look for Staph aureus and MRSA. And if you are positive, they will do a decolonization protocol in the hospital, and they will make that patient use a nasal antiseptic and wash their body with chlorhexidine. Brand name Hibiclens is very common, but CVS has their own, brand name of chlorhexidine, and they take a wash for 5 days before surgery to decolonize. The reason we do that is because 30 to 40% of the population are colonized with nasal Staph aureus, and about 5 to 10% are normally colonized with MRSA. They carry it around, they don't even know it. It doesn't cause them harm, it's part of their normal flora. But if they wipe their nose because it's itchy with their hand, and then they go and turn and take care of a patient, and they didn't sanitize their hands before they touch that resident or patient, they can transmit it. And patients with colonization of either Staph aureus or MRSA, they are 14 to 24 times more likely to become infected if they're in a hospital setting. So we know that the nose can transmit it to the hands, the can transmit it to fomites or to the body. So we get all those sources of transmission. So therefore, we've been, for many years now, using these various antiseptics in the hospital, especially before surgery, or if in the intensive care unit. There are some that are alcohol-based. There's an antibiotic prophylactic called mupirocin. There's povidone iodine that's available, and there's even a UV light box that was developed to put into the nasopharynx to kill. So you imagine all the time and carrying that thing around with you. The one that's really come out being the best accepted has been the nasal alcohol-based antiseptic. And that is one I use every day, and it gives you up to 12 hours protection. What's in it is not just alcohol like a sanitizer, but it has orange oil, so an essential oil of orange, which kills viruses and bacteria. It also has benzalkonium chloride, which is a very mild antiseptic, and jojoba oil, and that's what gives it that 12-hour protection. The povidone iodine has about a 10-hour protection, but these are used pretty much just before surgery. It will give, within an hour before surgery, they'll put it in the patient's nose, and that has shown to reduce infections in surgery by getting rid of the bacteria in the nose. The problem with mupirocin, it's an antibiotic, it's not an antiseptic, and it's expensive, and they can develop resistance to it pretty quickly. The organisms will outsmart it, kind of like what COVID variant strains are doing right now to us. They're outsmarting us and developing these variations, but the alcohol one is one of the best ones. Let's look at hand hygiene and how we optimize PPE. I'm going to talk about how soap destroys SARS-CoV-2, which is fantastic. We know that plain soap will kill it. And what's hand hygiene? Some of the steps to hand washing, versus hand sanitizer use. The WHO, there are 5 steps to the hand washing moments. And there are 2 video links that are here that you can then share with your staff if you want to do reminders on hand washing and hand sanitizing, and how to, some of the website access to CDC strategies on how you optimize your PPE. So we were really delighted when the research came out that found that soap will destroy the SARS-CoV-2 virus. What happens is the soap molecules wedge themselves in the fatty membrane that's around the virus. It's a lipid, we call it a lipid membrane, and it'll pry it apart. So this was great news when that research came out and showed us we didn't have to use antiseptic soaps, that just regular soap was going to work. Washing your hands, avoiding touching your face, especially your nose or your eyes, keeping distance with the social distancing, and regularly cleaning your environments are some of the control measures. The WHO years ago came out with the 5 steps before touching a person, before doing any kind of clean or aseptic procedures, after a body fluid exposure, urine, feces, sputum that you have to clean up, right after you've done that procedure to go sanitize or wash your hands. In that situation, I'd want to be able to get rid of the body fluids. After touching a person, that you go in and take a blood pressure, check them, their pulse or fever and temperatures, and you want to come out, yep, sanitize then. And after touching surroundings that are contaminated, if you go into a quarantine area and you might not even know that you leaned on a chair and you touched it, or you were kind of leaning on the nurse's station, and when you come out of those settings, to make sure there's sanitizer for people to sanitize. So using soap and water, covering all the surfaces of the hand, washing between the fingers, nails, and the tops and thumbs. A lot of people forget the thumbs, by the way. They just wash the palms of their hands and they don't do the backs or between the fingers or the thumbs. And singing happy birthday or saying the alphabet twice, it will give you about 20 seconds. Using the paper towels to shut off the faucet so you don't recontaminate your hands. Obviously washing before and after going to a bathroom, and after you cough or sneeze or blow your nose, to make sure you sanitize. You know, it's really helpful to carry it with you. Most of us now have little bottles on our body. Some you can wear around your neck. I do that when I'm going into a public area. I wear a lanyard with a little bottle of Purell around my neck. So I constantly have it available to sanitize. So this is a YouTube video from the CDC, this link here that you can share with your staff. And here's another one on hand sanitizer, very brief. This is like 36 seconds, but it shows the proper way to use a sanitizer. Similar to the hand washing. A lot of people forget, they often just put it on the front and they forget to go the full between the webs of the fingers and on the thumb and on the back of the hand. So putting on PPE and doffing or taking it off has a certain sequence to do it. And I know probably a lot of you went through this last year where you had to train your staff on the proper way or help one another. I know myself when I'm in some of these settings, if we're, for instance, in a nursing home recently, and I had to have somebody help tie the back of my gown so that I wasn't reaching back there contaminating when I was taking it off. People were untying it for me. So donning is performing hand hygiene. You put on the gown, then you put on the mask or the respirator. You put on your eye protection, you then perform hand hygiene before you put on the gloves. So many people ask us about that. Why do I have to sanitize my hands before I put gloves on? And the reason for that is we have residual bacteria on our hands, and then we have transient bacteria. So residual, it's kind of like the same in your nose. It lives with you all the time in your pores, and you have your own normal flora. And then at times you pick up transient. You picked up something from a counter or a doorknob. The bacteria can multiply every 20 minutes. That's how fast they replicate. Not 9 months of hard labor. 20 minutes, they are doubled. 20 minutes more, they're tripled. And so when you have gloves on, your hands get very sweaty. If you've noticed, you know, and you're working with somebody for an hour or so and you've got gloves on, you want to make sure you've sanitized your hands so the residual bacteria won't grow, and you won't have a huge amount of bugs on your hands when you go to take the gloves off. And that's why you want to sanitize after you take the gloves off. You go and do hand hygiene. So when you're taking things off, first remove the gloves so that your hands are going to be contaminated now. And you're going to take the gown starting at the top shoulder and roll it inside itself. And it's going to go over your hands, the contaminated part of the gown. So you take both sides and then roll it. You roll the gown to confine and contain. the contaminated part, which is the front for the most part. Then you're going to get hand hygiene because your hands now got all that stuff that was on the gown all over them before you start touching your eyes, in your hair. So before you take that eye protection off, sanitize. Now you take your mask off, and now to finalize, you perform hand hygiene. So there are really good posters on this website that you can download. I know a lot of you have signage around your facility. So, they update all of this. So keep checking to see what the latest is, and it might be something you can change periodically to catch people's attention. Signage should be changed, by the way. Otherwise, people just don't see it. They see it the first time, but then after that, it just is a blur to them. So it's good to keep stimulating them by changing your signage. Now, optimizing PPE is a whole website that CDC has. It was last updated actually back in July, so they really haven't done many changes to this. But general optimization strategies are described. There's a whole chapter on the N95 and respirators and face masks, and then eye protection gowns and gloves. Basically, they have it in 3 categories. Conventional capacity, so you have to determine what's going to happen conventionally every day, what you're going to do, and here's just listing of conventional strategies. Contingency capacity, when you're really reaching, your level of getting into PPE shortages, what to do and how to, for elective cases, they had all kinds of recommendations there for decreasing length of stay and all that. And then a crisis capacity, which many hospitals went into last year. As I said, things are much better right now. But again, this is worth those of you who are directors of nursing or administrators to get on here and just kind of get familiar with what the different recommendations are and whether you're following those if you're starting to see PPE shortages. Many of us in infection prevention have now access to different companies that might not be part of GPOs, like a Premier or, Yankee Alliance or some of the ones that facilities are usually involved with. And we have companies that have warehouses full of PPE available. So if you ever have shortages, I don't mind you getting in touch with me through Commonwealth Medicine, and we'll get you access to those different manufacturers and vendors. So now we'll talk about an infection prevention and control plan and what that would entail for your kinds of settings. So the recommended routine infection prevention and control practices from the CDC updated on February 23rd is to implement telehealth if possible. I know myself, I've done a few telehealth and it's much easier than having to drive up into Boston to get an appointment. Screen everyone entering the residential care home for signs and symptoms of COVID. That's such a simple thing to do, like a signage, a big poster board, and you ask, have you got any of these symptoms? People are used to this now as you go in and out of different places. And then signing, a lot will have you sign your name so they know that you were there and the date in case they have to do contact tracing, and they're usually taking that temperature. Many places are still doing that. Even restaurants are still in some settings, still taking your name and your phone number, again, in case they have to do contact tracing. Reevaluate admitted residents consistently for any signs and symptoms of COVID. That's really important. That's one of the best control measures. Let's find it early enough that we know that this person's acting a little different. Their mental state's off a little bit. And don't be looking for, fever to be the ultimate sign. In your settings, you have to be a lot more conscious of their normal everyday mental state and what looks like they're off, as we say. Implement universal source control measures like the masks and PPE, encouraging the social distancing. Consider performing targeted COVID testing. We talked about that, of those with or without symptoms. Optimize the use of engineering controls. I talked a little bit about that with those air purifiers, HEPA filter units, or opening the windows, or you see a lot of places have implemented plexiglass shields so that they can just, if somebody's got COVID or they cough, the droplets hit the shield and not come flying into your face. And that's the same concept of people that wear a face shield. They're not going to prevent things from getting under the face shield. So at times I've seen people just only have the shield on, but no mask. The mask is the most important thing, to have it not get into your nasopharynx. But this prevents your eyes, major things, from shooting at your face, and create a process for how you're going to respond to exposures among healthcare professionals and others. The second category they recommend is that what are you going to do for your practices when somebody is suspected or confirmed? establishing reporting within and between residential care homes and the Department of Health. I am sure you've done all of these already. Identify resident placement for cases or quarantines or cohorts. All of that has to be determined and probably already was. Your PPE, especially training. It's amazing how people have never had, if you think about it, have never really had to wear this in the past. And they've not had any training, especially the public. Nobody really sat down and showed everybody the right way to do hand hygiene or to wear a mask properly and dispose of it. In your setting, identify your aerosol generating procedures. Any of the residents that may have their severe asthmatics and have to have nebulizer treatments done, or they do have a CPAP. For a time, you can discontinue the CPAP without having serious effects, unless they're really on oxygen and it's, really severe case. But that might be something you do while they're just going through the first, week or so of their COVID infection, and then get them back on it when they're no longer infectious. Describe how to collect the diagnostic respiratory specimens properly if you're doing them, and collecting them, making sure that person has been trained properly. I'm sure that's already been done. Manage visitor access, and they're starting to loosen up on that. So again, you have to figure out what is your plan to allow residents to have visitors actually in the home, and what you'll do, whether you'll do the screening and so forth. And then the disinfection and cleaning schedules, making sure that their surfaces are being routinely cleaned, and not just that it's an afterthought that somebody says, oh yeah, I got to wipe down this table, but you have a plan in place for that. And so the plan should describe your in-service education program. How often are you going to do in-services in educational programs, webinars like this? You could share the CDC websites, and doing those pretty consistently. A lot of places have set up a year-long monthly webinar and use a lot of things from CDC to keep the education going and keep it fresh in their mind. Competency-based training, that you actually observe how they do their hand hygiene and check them off, that they showed you the proper way to do a hand washing or a hand sanitizing. And they also showed you the proper way that they donned and doffed their PPE, and have that recorded that there was a competency done. How you're going to do your social distancing in your settings. What are you doing for your dining? They're all still eating in their room? Are they being allowed to come out now in a schedule where you'll have social distancing, but two, different servings of dinners and meals? Cleaning and disinfection schedules. What's going to be cleaned, how often, and with what? How to quarantine, isolate, and cohort described in your plan. Screening new admissions, visitation protocols, and your respiratory protection program. Now, as you know, the NIOSH and the CDC recommends fit testing for these respirators, but that's been a severe challenge for your types of settings, and also nursing homes and congregate care sites. There are some outsourced companies that will do this, but they're very expensive. So often what has happened is we'll have a champion in these kinds of settings that will test that person and make sure, again, a competency, that respirator they chose, the small, medium, or large, does indeed fit their face. That's the key thing, is that there's a seal around it and it's not got openings on the side. One of the best ways to tell is that you put glasses on, and if the glasses fog up, then you don't have a seal. That's a given. So make sure that you have figured that through of how you're going to check for respirators. Now, we got some really nice recommendations. We did this training with the congregate care sites a few months ago. And some of the things they told us they were doing were this individual training and modeling, installed sanitizer dispensers. These were in settings away from the residents, so that the nurses and the staff could have better access rather than always rely on having a bottle of sanitizer in their pocket and remember to carry it. They created different languages for the songs for the hand washing. So they had happy birthday in different languages for them to sing, because you very often have staff that have speak multiple languages. The consistent use of masks, disinfecting rooms right after use. They had scheduled hand washing for the residents. So they assured that at least once an hour or whatever they came up with, that people were washing their hands. So they knew that it was getting done pretty frequently. They had signage and incentives. I'm going to show you some work that I did at New England Baptist Hospital in Boston when I was the head of infection control there, to make things fun and interactive and consistent. we're so busy, our minds these days, that we need to have constant reminders and to encourage protocols. One setting had prepackaged PPE so that those who travel, they had travel kits for residents who were working outside and, in other settings. I know I worked with the police force up in Boston, and that's what they were doing. They had somebody in their locker room who put together, Ziploc baggies that they bought at the local dollar shop, and they would put all the equipment in there so they actually had a package to go out the door with. The one-way entry and exits, I know, are a big challenge in your settings. That's just so that people are not, if somebody's infected, they're not coming by you, coughing or sneezing, and you're in their airway. It's better if everybody's flowing in one direction and coming out another exit. But again, that probably is going to be almost impossible in some of your settings. Conversations around deep cleaning, making sure people will identify what needs to be cleaned, how often, and with what, and who's going to do it. That has to be, we have all these environmental service grids set up, these cleaning schedules in healthcare. You can imagine with all the equipment that we have, and they work once you get them in place. It's not just EVS that does this. Everybody has to pitch in. And then some have positive rewards that have done, pictures and video guides, reinforcing the 6 feet apart. They divided their eating areas, Zoom meetings for trainings. Arm's length and 2 steps back was how that with residents, they were figuring out the social distancing. If people were in line waiting for something, limited the number of residents in groups and dining areas, provide additional items to limit congregating, limit on-site visits to providers only. As I said, visitation starting to open up in many places. Opening the windows if they're being transported in vans, visual aids to show social distancing. They're designated areas for mask breaks. They rearranged all the furniture to increase spacing, sneeze guards, and no visitors or limited visitors, as we talked about. Other things, staff use their vehicles for breaks if they're allowed to go outside. That was where some of the staff would go and have their breaks, or a designated staff-only break room, limiting the number of staff in the room, having designated break times for the staff. They did close common areas. Some of those are starting to be opened up with limited number in the room, and again, social distancing, and then sanitizing the hands, and then cleaning the environment right after the groups have been in there. Reserve open spaces where staff can be alone. Last year this was really challenging mentally for staff, and so they really started to look at their mental state. And when there's nice weather, have the breaks outdoors and designate mask break areas. Outdoor separate areas for breaks without a mask on, or if they're together, an area that can be together, but they have to wear the mask. So let's look at cleaning and disinfection, decontaminating surfaces and equipment with the right disinfectants. So basically the recommendation has been that you use the EPA, there's a link down below, and probably all of you right now do have. Last year there was a bit of a challenge where people didn't know what a disinfectant they could use for COVID. So, but what we talked about, normal routine cleaning with soap and water removes germs and dirt, and it does kill the COVID virus. But that's for cleaning. So if you want to first clean something, say somebody did have a urine or feces spill, and you're cleaning up the particular matter, you clean basically with a detergent or soap and water, and paper towels and gloves on, a bag where you put it in, confine and contain it. Then you put the disinfectant on top of that area for final disinfection. And you leave it for the appropriate contact time. So on the bottles, they will tell you how many minutes, in some situations, seconds, the contact time is. The lower, the better. So you don't have to wait around and say, hey, we need 10 minutes that you can't go in this area for it to work. It's better if you have something that's less than a minute or 2 minutes. Be careful that they don't mix disinfectants. Bleach can't be mixed with any other kinds of products that can cause toxic fumes, and keep them out of reach and safely stored, and wearing gloves or whatever else the back of the bottle tells you. Some of them tell you have to have personal protective equipment on, such as gloves and a face mask to protect the eyes. Some of the common disinfectants that can be used, a lot just from the Clorox company or from Lysol, and you can see the contact time. So it's better to use the ones that I mentioned that have a lower contact time, so that you can get that area disinfected faster. And even in some settings that had a hard time accessing or couldn't afford the price of some of these disinfectants, they just started to mix liquid bleach or sodium hypochlorite solution of how many teaspoons of bleach to a cup of water, and using that in that quantity, because you just can't go and put a diluted gallon of bleach that you've used, I don't know how many cups to a gallon of water, and leave it, because it has to be replaced every day. It starts to decompensate as soon as you dilute it. So that's why we recommend you use it more like this concentration, small ones, just a cup. And when you're done, you go and get another one, but not leaving it around in the environment. So here are the 6 steps that the EPA talks about. Checking it's EPA approved, and this is the EPA link to the list. So if you're using Lysol or Clorox, all of those are EPA approved. Read the directions, pre-clean the surface as I mentioned, then you disinfect it. Follow the contact time, find out how many minutes it should be on the surface. Make sure you wear gloves and wash your hands after you've done the disinfection, and locking it up. So here's the link, the website of which ones are registered by EPA. Remind people to, anything that's portable and shared items like cell phones and any kinds of telephones, that those get cleaned often. This is where we can have that indirect transmission. And one person answers the phone, another one grabs it right after and hasn't sanitized their hands. So these should be disinfected frequently. In the work areas, kept clean. We talked about avoiding the handshakes and hugs and close contact and sharing personal items. And, and most important is to make people know that if you don't feel well, please stay home till you get tested. It's so easy today to be able to get a COVID test. So many sites opened up. It's usually not an issue like it was last year. So it just makes sense that if they got a scratchy throat and they've got a fever, that they just stay home and go get a COVID test and see what's going on. There still are other common colds that people get that aren't COVID. So that's part of the problem, that we have to the only way to know is to test people. So CDC and the Mass Department of Health recommends to continue social distancing to reduce the spread. That 6-foot distance is ideal. 3 feet is better than not at all. So, to be able to cut back on this transmission, separate tables, decreasing the number of residents in a shared space at one time, and staggering dining schedules. Implementation, I've had to do this throughout my 40+ year in infection control, is how do you get people to change behavior and attitudes? And I was fortunate that I went to a master's program that was based on education. It was called Social Learning Theory and Health Promotion. And I purposely did that type of program rather than epidemiology, because that was always my biggest challenge. I was the director of infection control at Mass General Hospital at that time that I got my master's in education. We had 22,000 employees. We were in 3 cities. We had 1,000 beds. We had so many people and patients, and we had to implement the bloodborne pathogen standard. And we were able to very successfully implement it using these principles called social learning theory. So role modeling. We got people to be role models. We got the chiefs of services, the chief nurses, the managers, all trained to train the trainer, and they would demonstrate the practices. They would be the educators and the communicators. They would role model, like, if there were rounds going on, the chief of surgery would sanitize their hands before going in a room, and every resident and medical student behind them sanitize their hands. Other studies have shown if they didn't, nobody would. It's a follow the leadership. And so role modeling is really important. I used to clean the computers on wheels or workstations on wheels once a week. I would go up and make sure that all of the workstations on wheels had a bottle of the PDI wipes, the purple top wipes, and I would then start cleaning the computer. And I remember the nurses would look at me go, like, what are you doing? And I said, well, I want to make sure that these are cleaned once a week at least. I said, I don't want any of you to get infected. We had a lot of influenza going on back then, that H1N1. And after a while, and I would clean the nurse's station, I would clean the telephone. It took me all of maybe 10 minutes to do it. Once a week, every Wednesday, I'd do this. And I remember then I'd start coming up and say, we already beat you to it. We just did it, with a smile on their face, that they saw it wasn't beneath me to clean, to make it safe for them. And that self-efficacy increases self-esteem through recognition that they meant something to me, that I didn't want them to get sick. So we'll talk about that self-efficacy, how you can improve the self-esteem of your staff, and by role modeling the behaviors you want, providing reinforcement and feedback. You need consistent messaging. I'm a mother to 5 children, and I can tell you, and any of you have kids, you know that constant reinforcement, role modeling, improving their self-esteem is how you sculpt them to proper behavior and attitudes. Contracting, we would have raffles consistently every other month. We were in the cafeteria with a big hand hygiene display. And we would, I would buy I don't know, I'd go down to one of the shops and get a cheap, around Easter, I'd get a big bunny, stuffed animal out of a dollar shop or down at CVS trying to get rid of things after Easter. And we'd raffle them off, and people would have to sign a pledge. It wasn't just putting your name into the big fishbowl. It said, I pledge to do better hand hygiene. And that's a contract. In your head, it works. Your body believes every word you tell it. So if you write a pledge or you sign a contract, whether it's verbal, a handshake, or it's a real contract, you're held to it. Reciprocity, we gave them gifts and cards and, sanitize, little bottles of sanitize. We engaged them so that they felt respected and had gratitude for our infection prevention program. So I'm going to show you some of the examples, and they're all on this website. We didn't, by the way, copyright anything. We felt anybody should be able to use these ideas. We were very fortunate that we had a very creative group of unit-based champions, infection prevention champions, who came up with the greatest ideas. Now, orthopedics, which is what the Baptist does, is a high-risk population. So we had the surgeons on board as well, because they did not want any of their patients to get infected. So I worked there from 2003 to 2010 after I left Mass General. I was the director at this program. And again, we did it at Mass General. We implemented creative multimedia kits to get universal precautions implemented, and we did it at the Baptist. So you could have residential care home infection champions like we had in the hospital. They can serve as your role models. They can be responsible. They have responsibilities that enhance their self-efficacy, participate in educational activities and hand hygiene observations. Maybe they could collect 10 a week. And there is an app you can use called iScrub. It's an app for hand hygiene, and you can just put it right in the phone, whether somebody sanitized going into the room or out of the room. Isolation observations. Do people wear the proper PPE in a COVID case? Communicating information to the staff. This is one of the infection control boards that one of the unit-based champions put up with little bugs, and she was trying to educate them about all the organisms. Call out breaks and technique. We actually had a program where it was acceptable for a staff member to call out a surgeon even if they didn't sanitize, and nobody would get repercussions for that. It was accepted by management. Call out and participate in performance improvement programs. We got the patients involved one year. We gave them these little finger puppets that we got off orientaltrading.com that a lot of teachers used, and we searched for monsters, they were called. But we gave them to the staff, and we said, when you come into the hospital for your surgery, bring your little bug. And if you see somebody not sanitizing their hands, bring your bug out and tell them. And everybody, the staff were trained and scripting back saying, up, you caught me. I am so sorry, monster. And it became more of a positive thing. We also use glow germ. You can see here these handprints with fluorescent powder. And then there's a fluorescent box that you put your hand in. So we went around the hospital and put the powder. We powdered the elevator buttons, the telephones, the door handles. And then as people came through the cafeteria, would say, put your hand in this box and let's see if you picked up anything. They were shocked. Their face, when they saw they had powder all over their hands, they're like, where did I get this? And we're like, we don't know. I mean, it's all over the hospital, but that shows you how bugs can transmit. There are other giant micro stuffed animals. One of them's actually on COVID. We got the staff involved with signage. Just take pictures of your staff, get their permission, legal contract there, and just make up, different signage so that you can see everybody's role modeling that we encourage hand hygiene and sanitizing. This one you could use, foam in, foam out. You can just cut off the New England Baptist and put your name of your residential care site, and that's how you can educate the staff. And we had foam for our sanitizer, so that's why it said foam in, foam out, but you could cut off the top there if you just wanted to use the organisms. Here are some don't catch the flu bear blues. We did this back in 2009 when we had the H1N1. And we were raffling off these big teddy bears and gave them out, these little teddy bears with sanitizer. We had a luau in the big cafeteria, and Let us always use good hand hygiene was what the luau represented. We had these Christmas trees with gloves. We had the monsters, they call them, but they look like bugs. We wrapped them around the sanitizers. We did a lot of really creative things to be able to get the program accepted by everybody. And the other thing we have to be concerned about is the self-care of staff. In these kinds of settings, you have to look at your staff and how they're being cared for. And one of the biggest ways we can care for them is through vaccination, being vaccinated. And so post-acute care facilities, including residential care homes, indoor visitation can, for unvaccinated residents, should be limited solely to compassionate care situations at the moment until the county positivity rate is greater than 10% and less than 70% of residents that are fully vaccinated. So this is where you're going to have to, you can't see right now the date, but it was like March 10th, I think it was, the update, revised March 10th guidelines from CDC on indoor visitations and limiting those solely to compassionate care situations. So you're going to have to take a look at this based on your county and guidance again from the Department of Public Health. When you can start to really get into visitations based on vaccinations. And the same thing with healthcare professionals. If they're fully vaccinated with higher risk exposures who are asymptomatic, they do not need to be restricted from work for the 14 days. Work restrictions for the following fully vaccinated healthcare professionals with higher risk exposures should still be considered if they have underlying immunocompromised state, if they have organ transplantation, meds they're on, cancer treatment. Those who have traveled should continue to follow the CDC and Mass DPH travel recommendations. Fully vaccinated residents should continue to quarantine following prolonged close contact with somebody with COVID. So there are all these guidelines are available on the CDC website and have been recently updated. But as of February 10th, the CDC updated said to implement the universal use of PPE it was updated to expand options for source control and resident activities in areas of moderate or substantial transmission, and they updated strategies for improving fit of face masks. So again, you want to make sure that if you're in a leadership role, that you look at this particular one, the reference on optimizing PPE supplies, using PPE, the frequently asked questions, and the PPE burn rate calculator that's available on this website. Making sure your staff have self-care, they stay healthy, avoiding things that deplete immune function. I think last year, a lot of us, myself included, maybe increased a little bit more relaxation with alcohol and sugar. And both of those, unfortunately, have been shown to reduce immune function. But a lot of people gained weight last year as they were quarantined and at home. And so now they're kind of learning, take care of yourself with stress reduction, whether it's stretching and walking and yoga and meditation and prayer and things that are going to get your immune system pumped up and reduce alcohol and sugar intake. Also, guidance from March 15th, the CDC has updated guidance for employees and businesses, educators, individuals, consumers, parents, and caregivers. So all of these have been updated on March 15th. And as I said, it's just constantly keeping on top of what's coming out of not just the CDC, but federal, state, and local governments, tribal agencies, global health. So we're all aware of what the different guidelines are. But here's some of the references for you: the Mass Department of Health, the CDC, the EPA, and on isolation, hand hygiene. And here's a whole other bunch of videos that we recommend that you can share with your staff. As I said, set up maybe an educational schedule, and once a week, once every other week, once a month, you just use one of these videos and just say, this is going to be our educational focus this month. We're going to focus on hand hygiene this month. Next month, we're going to focus on PPE. The following month, we're going to focus on how to put on N95 respirators. And you can just set up your own training. We do that in hospitals. I always had an educational schedule for the whole year for the staff, and we had competencies. And a lot of that now is very well managed through these companies that have on-site software programs that we do the training through them. So I'm just going to turn it now over. I'm going to come out of my screen and turn this over to Jessica so she can give you an idea of the work we do at Commonwealth Medicine. It could help you with consulting or education or other needs that you might have. So all yours, Jessica.
Thanks, Maureen. Can you just put that slide back up for me?
Oh, yeah, I'm sorry.
That's okay. And I'll just take a minute so we can spend the remaining 15 minutes focused on questions with Maureen. So thanks to Maureen for giving us this huge amount of information in such a short period of time. I just want to share with you, Commonwealth Medicine's consulting offering in the infection control space. We offer and provide infection control and prevention advisory services that are individualized for a facility based upon their specific needs to support compliance with infection control practices. So we have a number of different offerings, and we can, structure this again in a way that would meet the needs of any particular facility or group of facilities. We offer on-site assessment where we have a team that comes out who can provide a focus on the infection prevention practices. We review your infection prevention plan or policies or procedures, any existing material, communication strategies, and really work with you to not only review those, but conduct some focused staff interviews, meet with leadership, review workflows, and work together to support you in developing or strengthening any existing organizational prevention, performance improvement activities that you might have. And that might include creating your own infection prevention plan if you don't have one. Next slide, Maureen. We also have created self-assessments for different groups of settings. So we've developed one for congregate care settings for Massachusetts group homes. We've also completed one for nursing facilities. There's one on the CDC for nursing facilities that is really used for each setting to be able to evaluate your own infection control and housekeeping practices, risks. We can analyze that data, help you identify opportunities for improvement, intervention, any training or education needs, and then we can offer any additional outreach or in-person advisory services, including any type of training that you might need. Again, structured in a way that would meet the specific needs of your organization. The last slide just has our contact information. So this is for Maureen, Christine Dixon, who heads up our Healthcare Operations Solutions group, and where our infection control consulting offering resides, as well as myself. So, feel free at any time to reach out to us. I know you'll have this webinar recorded. I'll also make sure that Ron has the slide deck, so you can have that for your reference as well. So now I want to just turn it back over to Maureen. It looks like, Maureen, I'm just scrolling through the chat here. And the only question so far is whether the slides will be shared. And yes, I'll be providing those to both Sarah and Ron.
Yeah, and I don't mind any of you want to reach out to me at this website if you have specific questions, but I'll get these off to Ron, the slide deck. I know it's a lot, but we kind of wanted to go through each one of those categories. So that's another concept is which we have done with the congregate care sites. They took the slide deck and they took each section, and that's what they set up their training on. We're going to just show this part of the video on hand hygiene, this section on testing, this, so that you can do it that way and maybe just make it a little bit easier than to do all of it at once. So.
Great. Well, I am so thankful for this most informative and effective webinar. I think based on the information presented, I hope that this is a time for all of us, all of the restaurant community, to think about self-reflection, to think about self-assessment. And do we each have an effective infection control plan? I think that's the operative question, that we all need to be asking based on all of the information that's been provided. And again, we're so thankful for that. Another reminder, as you assess your PPE requirements, we do have with our relationship with Leading Age, value first. So just a reminder for that. And we certainly appreciate all recommendations Maureen, that you will provide us and can provide us. So again, thank you very much for that. And again, thank you specifically to our expert and presenter, Maureen Spencer. And thank you all members for attending. The journey continues. There'll be much more to cover. And again, we look forward to your ongoing participation. Thank you very much.
Thank you.